Hello everyone, and welcome back with a new case. This is a cardiothoracic case that's mostly for seniors, but juniors would find this useful. This is a CT on a 74-year-old female patient who presented with chest pain. The study was performed for the purpose of assessing the coronary arteries to make sure that there is no atherosclerosis or obstructive coronary arterial disease. Using the new CT technologies and that in combination with ECG synchronization, you could perform cardiac CTs. The cardiac CT examination in this case was performed in a fashion where the left side of the heart is opacified. For better orientation, this is anterior, this is posterior, this is right, and this is left. And this image here of the heart is what we call a four-chamber view. The reason we call it a four-chamber view is because you see the left ventricle, the left atrium, the right ventricle, and the right atrium in a single slice. Although in such examination you could nicely see the coronary arteries, this is a topic for another discussion. The reason I'm showing you the case is for something else. What I want you to concentrate on is the appearance of the cardiac muscle, the myocardium. The normal myocardium has a density that's of soft tissue. So this soft tissue density, as you see here, is similar to the soft tissue density of the muscles in the chest. Now look at a different density, which is here. This is the skin, this is the subcutaneous fat. So fat has this kind of color, which is dark, and that's very similar to the fat that you have inside the chest, the fat that surrounds the heart. If you look at the left ventricular myocardium, everything looks okay. Let's concentrate on the right ventricular myocardium, which is usually very thin. If I scroll up and down, you notice that the right ventricular myocardium seems to be darker than usual. It's very similar in density to fat. So there is fat deposition within the right ventricular myocardium. Let me show you this in a different view for better appreciation of the abnormality. Now that we agreed that this is a view that's called a four-chamber view, let's see what view you get if you cut the ventricle this way. When doing that, this is the view that you get if you look at the ventricle in a short axis plane. That's why this plane is called a short axis view. In this view, you could see how the left ventricle looks like a circle or a donut, while the right ventricle looks a bit different. On the short axis view that you see here, you will notice that the left ventricular myocardium is of homogeneous soft tissue density. Compare that to the right ventricular myocardium, which is in normal cases difficult to see and should also be of a thin, linear soft tissue density. It's not the case here. You could see some intramyocardial fat, and if we scroll back and forth, you could appreciate that even better. Here's a magnified image where you could see lots of fat within the right ventricle. So this is fat within the myocardium. Now, what are the reasons to have fat within the myocardium? The commonest reason is an old myocardial infarction. To understand this concept, this is very similar to what you get with bodybuilding. A muscle that's active is full of soft tissue, while a muscle that's not active becomes atrophied and replaced with fat on the long term. The same thing happens within the myocardial muscle. So seeing fat within the left ventricle is commonly associated with an old myocardial infarction. Another less common but famous reason that I'm sure lots of seniors are aware about is called arrhythmogenic right ventricular cardiomyopathy, ARVC. ARVC is a very rare condition that is inherited, and that's a cause of arrhythmia and sudden cardiac death, especially in younger patients. The pathology here is infiltration of the right ventricle by fat, fibrosis, or both. And that's thought to be the reason why the patient has arrhythmogenic foci that could lead to, God forbid, sudden cardiac death. Although ARVC has been described in the right ventricle, it has also been described despite its name in the left ventricle, and it's not only the younger population that gets it, you could have elderly patients who have it as well. Now, the most important thing to remember is that ARVC is a clinical diagnosis where the patient could be symptomatic in one or another way. In the case of ARVC, you'd have clinical signs, family history, ECG changes, or even histopath proof. It's important to remember that this patient here is an elderly patient without any family history or ECG changes, so the patient does not have any arrhythmia or syncope or related findings. This brings me to a very important teaching point for seniors. If you see fat in the right ventricle, never call ARVC unless there is a clinical question about it. First of all, it's a rare disease. Second, the patient should have some of the findings that we just mentioned: family history, ECG changes, or others. So if the fat here is not related to an old myocardial infarction, is not related to ARVC, what's the reason? The reason in this case is much more simpler than what you think. It is well known that fat deposition within the myocardium, especially within the right ventricular myocardium, could be normal. And the incidence of seeing this and the amount of fat increases with increasing age. Remember, our patient is 74 years old. Always link the appearance of fat within the myocardium with other findings and with the patient's clinical presentation. Never call an MI if you don't have signs of that or if the clinical does not support it, and the same applies to ARVC. Never call it if the patient was not questioned clinically for ARVC. Remember that right ventricular fat is really common in older patients. Now, for radiology residents, although this is a cardiac case, this is not really subspecialized. Such findings and discussion could be seen on any chest CT that you get during your duty or during on-call time. So keep this piece of information in mind. Now, summarizing what we talked about today, cardiac CT for assessing the coronary arteries and the large cardiac structures is possible nowadays using new technologies with ECG synchronization. Although we didn't talk about all the cardiac planes, we learned a little bit about the four-chamber view and the short axis view. We learned that there are various reasons for having fat within the myocardium. The commonest would be an old myocardial infarction. Another famous reason would be arrhythmogenic right ventricular cardiomyopathy, which you should never call if the clinical presentation is not supportive. It's important to remember that fat deposition in older patients, especially in the right side, is a common, normal process. Thanks for watching. That's it for today's case. Please don't feel shy to send me your comments and questions. If you find this useful, please help by spreading the word about the RadBits accounts. Thanks again, and see you with more cases later. Hello again. This is a new case that's mainly dedicated for senior audience, but juniors would learn a thing or two from it as well. This is a 23-year-old male patient who had the CT scan done for vague abdominal pain. Now let's concentrate on this abnormality. For junior audience, you're looking at the patient from his feet. This is anterior, this is posterior, this is right, and this is left. As we're going down from the abdomen into the pelvis, we notice this abnormal finding here in the midline just posterior to the anterior abdominal wall. The abnormality itself is of homogeneous density. It has the same color. It has no perceptible wall and has no surrounding changes in the mesentery. This is the mesenteric fat, so there is no fat stranding and there are no nodules around it. The lesion itself does not invade the abdominal wall. The density of this abnormality is relatively low, and when measured, it's equivalent to fluid density, so it's a fluid-containing cyst. At this point, let's try to think about a reasonable differential diagnosis for a fluid-containing cyst within the abdomen. In patients with a prior history of pancreatitis, you may have cysts within the mesentery, cysts that we call pancreatic pseudocysts. However, in this case, the patient has a normal appearing pancreas and had no history of pancreatitis before. Another potential consideration would be that of a mesenteric cysts. These are usually congenital cysts within the mesentery that contain fluid, and they may occur anywhere. A third option would be a congenital duplication cyst of the GI tract. Typically, those cysts are of a slightly thicker wall because they have a mucosal lining similar to that of GI, and this is not what we see in this case. Another option would be that of loculated ascites. In that case, you typically see ascites elsewhere, which we don't see here. A type of vascular malformation is a lymphangioma or a lymphatic malformation. This could actually look like this. Has thin walls, fluid content. Typically, it's more lobulated with septations. If it has venous elements, it might have calcifications known as phleboliths. And if it's large enough, it actually accommodates the space that it lives in, so it insinuates itself between structures. This is a male patient, as we mentioned, but if this were to be a female patient, a potential consideration would be called a peritoneal inclusion cyst. This is a condition that occurs in females of reproductive age where there are ovarian secretions that are trapped within the pelvis. So usually the location of the abnormality is lower down in the pelvis surrounding the uterus and ovaries. It's usually lobulated, septated, and loculated. And this is not a peritoneal inclusion cyst given the patient's gender as a male patient and the overall appearance. Whenever you see a cystic structure within the mesentery, try to think about necrotic soft tissue abnormalities. By that, I mean a necrotic metastatic deposit or a necrotic lymph node from either neoplasm or infection. However, in such cases, you would expect the appearance to be more complex than what you see here. You'd see some thickened walls, you'd see some nodularity or more soft tissue components, whether inside or outside of the cystic structure. So a necrotic lymph node or metastatic deposit does not apply here. Another reasonable option would be that of an abscess within the mesentery. With abscess, the patient's presentation would be different. It's usually that of fever, leukocytosis, abdominal pain, and tenderness. And you typically have a cause for the abscess, a perforated viscus, previous surgery, or others. Add to that, imaging-wise, you'd see a more complex appearance. With abscesses, you typically see some inflammatory changes surrounding the cystic abnormality, which is not the case here. Now, after discussing all of these options, none of which represent this case. So, what is the real diagnosis here? The most important observation is that this simple cystic abnormality has an anterior midline location. It resides immediately behind the anterior abdominal wall. As you see here, it's abutting the rectus muscles. And if you look very carefully, you'll observe that it has this dot-like linear communication all the way down with the urinary bladder. This is the sagittal image for better assessment. So in this image, this is anterior, this is posterior where you see the spine, this is superior, this is inferior, and here you see the urinary bladder. You could see here the urinary bladder that's filled with fluid has a linear-like connection to the cystic abnormality that resides anteriorly within the abdominopelvic area, and then continues with this linear connection going all the way up to this location here. This here is the umbilicus. The connection between the dome of the bladder and the umbilicus is known as the median umbilical ligament. The median umbilical ligament represents a fibrous remnant of what was there during the embryological development, something known as the urachus. So without going into many details, the urachus in utero was a connection between the dome of the bladder and the umbilicus. This canal usually obliterates and becomes fibrous, sometimes seen on imaging, known as median umbilical ligament. Now, if you have this umbilical ligament canalized for any reason, you have a spectrum of abnormalities known as urachal abnormalities, and this is what we'll talk about now. So if this ligament remains patent from the umbilicus to the dome of the bladder, we call it a patent urachus. If the urachus is closed from the side of the bladder and opened from the side of the umbilicus, it leads to a sinus known as the urachal sinus. This urachal sinus could present clinically with umbilical discharge. If the opposite occurs, where you have obliteration of the urachus from the umbilical side and patency from the bladder side, you'd have what's known as a urachal diverticulum. And you could actually see that here. So you have a small urachal diverticulum rising from the dome of the bladder. If only the mid-course of the urachus is patent, with occlusion at the umbilical side and occlusion at the bladder side, you'd have this remaining structure, which is called a urachal cyst. So here you see a urachal cyst as well. So the diagnosis here is a case of incidental asymptomatic urachal cyst and urachal diverticulum. The abdominal pain in this patient was not related to the finding, and this was incidental and asymptomatic. And these findings are commonly asymptomatic and seen on imaging. Another potential presentation is related to stasis, where you have stone formation or recurrent infections. Finally, and rarely, the stasis may lead to irritation of the lining of these urachal remnants, and this results in metaplasia of the mucosa, and this may result in forming carcinoma. In these cases, for seniors, remember that due to metaplasia, the carcinoma that you have here is not transitional cell carcinoma, it's adenocarcinoma. That's why when you check these structures, make sure that there are no soft tissue components, whether a thick soft tissue wall, nodularity, or even calcifications, since that would raise the possibility of either stones or formation of adenocarcinoma on top of a urachal remnant. In such case, where the finding is incidental and the patient is asymptomatic, the treatment is a bit of a controversy. In general, if the patient has any symptoms or presents with what seems like a malignancy, resection would be the way to go. To summarize what we talked about today, first of all, if you find a cyst within the mesentery, you have a differential diagnosis to go through. First of all, make sure that there are no soft tissue components to exclude the possibility of a neoplastic or infectious process, such as a necrotic lymph node or a necrotic peritoneal deposit. Then, if this is purely cystic, it could be congenital in the form of a urachal remnant, vascular malformation such as lymphangioma, a mesenteric cyst, or it could be related to previous pancreatitis in the form of a pancreatic pseudocyst. Make sure to correlate this with the clinical presentation to exclude this being an abscess or a loculated area of ascites. To finalize, remember that this is a classic case. An abnormality that is located anterior within the midline along the expected course of the medial umbilical ligament is that of a urachal abnormality. The spectrum of abnormalities there could include a urachal diverticulum, a urachal cyst, a urachal sinus, or a patent urachus. Also remember the complications that may be associated with such an abnormality are those of stone formation, recurrent infections, and neoplasia. For MCQ purposes, the neoplasm that arises here is not transitional cell carcinoma, is most commonly an adenocarcinoma. That's it for today's case. I thank you for watching. If you find this useful in any way, form, or shape, please help spread the knowledge about the account.